Good morning, everybody. We're live. I apologize for the delay. We had some technical snafus at our end. It's a great pleasure to be here. Thank you for everyone's time. We are going to be talking about some pretty exciting topics. We have a great panel lineup. We're going to be describing how Seattle Children's has really revolutionized and optimized their surgery throughput and output and outcomes, leveraging real-world data captured by the EMRs. Specifically, we're going to be sharing some success stories of how we've managed to add an incredible 150,000 minutes to our OR capacity that's annualized, improve our outcomes, reduce our length of stay, and start working on racial equity and save the planet. I want to introduce the panel today. We've got Dr. Jeff Ojemann, who is our Chief Medical Officer at Seattle Children's, Senior Vice President, also former Surgeon-in-Chief. We have Dr. Sanjay Parikh, who is an otolaryngologist, Associate Surgeon-in-Chief, and also Medical Director of Seattle Children's Surgery Center. Dr. Elizabeth Hansen is a pediatric anesthesiologist. Ms. Kayla Reese is the Nursing Director of our Ambulatory Surgery Centers. And I'm going to be moderating. My name is Dan Lowe. I am the CMO of AdaptX, also a pediatric anesthesiologist. Very well, welcome to the call, everybody. And I'm going to kick off with, let me just do this slide. Jeff, could you describe, actually, could everyone mute for a sec, because I'm getting some feedback, except Jeff. Great. Jeff, could you describe this for our audience, the historical concept of Seattle Children's? I know, like many hospitals over the last decade in the U.S. have spent millions of dollars standing up their EMRs. Can you just give a quick overview of where Seattle Children's got to over the last 10 years or so with their EMRs, and what was the gap and what prompted leadership to install AdaptX?
Yeah, thanks, Dan. So I became Surgeon-in-Chief in 2019, and at that time, we have been uncertain, made the decision to move over to Epic, which we did just after the pandemic started. And we had invested quite a bit in a variety of mechanisms to use data. But what was clear to me is that we had a lot of good ideas and didn't have the ability to get the front line, the docs and others, and nurses and other leaders who had ideas. They didn't have the data at their fingertips. And, as for full disclosure, children and many children's physicians are investors in AdaptX. I am not, but it was very clear that this was a tool that was going to give us the meat, if you will, when we talk about terms like empowerment and agency, because now in real time, people can look at their own data. They can look as a team, as an individual, make changes, and then follow them in real time. And so, to me, this was absolutely critical. And we're going to hear a bunch of these stories, but we started with GI and had almost immediate improvement in turnover, in outcomes, and the fact that it touched the patient so quickly, to me, was remarkable. And that wasn't the first project, because you and your colleagues have been working in the ambulatory center for some time and had real concrete results. And that's the other thing that impressed me, is we weren't talking about improving the system or improving metrics that were distant from the patient. We were talking about less harm, better results, lower costs. And so improvement on every meaningful aspect of the term. So as we were able to launch then our other priorities, it became very clear to me that this empowerment, this ability to not wait for a ticket to go in and an analyst to review something, and you having to train that analyst on what the clinical question really was, that this could be applied throughout all sorts of not just different divisions and not just different services, but really fundamentally different questions, whether it be line infections and even into the world of health equity and, as you're going to hear, even saving the planet, quite literally. So the fact that all of these pressing problems that sometimes are overwhelming, if we can decentralize the analytics, it's just turned people loose in a way that truly untap their potential. and sky's the limit.
Thank you, Jeff. Sanjay, I know you were involved in the early stages of building capacity in the ORs with the AI project, and you were mentoring that team. And Kayla was also involved on the ASC side. Maybe just a quick word from both of you, Sanjay, first can you just describe how they got started with finding this additional capacity?
Yeah, I think what AdaptX did, and by the way, I should disclose I'm not an investor either, but what helped us was the rapid way by which AdaptX kind of takes data from what we call the warehouse. So this data that we all have in Epic or Cerner about timestamps, about, in the OR, they just sit nowhere, but they're in this warehouse. But with this technology, you're able to rapidly build data quickly, like, hey, when did I start, what's my start time? How much time do I have between cases? And then, for me personally, is there actually space? Am I underbooking? Am I overbooking cases? And so when we first got hold of this software, Kayla and I were sort of partnering, trying to figure out where are the opportunities and wins. And I got to give Kayla credit because she was the first to really say, hey, we can use this data to find out who our top performers are. Let's copy them. And then also figure out where are we actually, why are we may be underbooking cases, and we have space for more, which allowed us to do experiments. And I'll let Kayla speak to those experiments.
Yeah.
So I was the first clinical leader to use AdaptX, and the great opportunities I saw were exactly what everyone's sharing. As a nursing leader, if I wanted real-time data, I would go sit in the OR and observe with a stopwatch, or I would have to pull my nurses' data after the fact to go in and see what the time gaps were. This was the first time I ever had real data at my fingertips, and I could see it all very clearly, painting a picture of what was going on in my operating rooms, and it connected the outcomes and drove my efficiencies.
Yeah, I've just changed the slide for those who can't see it on the team. So this work started, it sounds like it started in the GI lab, kind of a reasonably low acuity area, and then the ASC. And then it spread pretty rapidly to the main campus. Dr. Ojemann, could you just share briefly, just the context, coming through COVID the last 2 years, can you give us the kind of the uphill challenge, and why was it a burning platform that we had to build capacity quickly? And then can you just talk a little bit about how we scaled what we call maximum capacity project across the main OR?
Yeah, thanks. So, some of this, of course, predates COVID. In fact, the timing was, a few more years, where we launched the GI initiative in December of 2019. We saw the first month results where we were able to take a group of providers that were almost all at the exit door because they were consistently going home at 7, 8 o'clock, and now same book of business being done at 3, asking if can they, their schedule is to put on more cases. And then, of course, within a few weeks, we're shutting things down, adding, especially with GI, adding enormous amounts of time between cases. But we didn't stop and continued to look for other places. We did have, as everyone knows, the waves of no business, lots of business, and then a backlog that is, for us, banging at the gates to get in. And so even as we're about to open up some ORs where the construction started 5, 6 years ago, we already know that we're going to be back to a capacity-limited state in the very near future. And every force that's out there, whether it's economics to staffing and the patient demand, looks to us like we have to make every minute count. Yeah. But again, I can't overemphasize the power of that individual thing, because what you saw then is the success then went to the urologist wanted to do a project, general surgeons wanted to do a project, and so our ability to look at each individual variable and then make improvements and then iterate.
Yeah. What we've got on the screen is the latest procedural area at Seattle Children's. So we have the main operating rooms, obviously, and other peripheral areas such as the cath lab, and what we're seeing here is the interventional radiology lab. So this is a pretty high acuity area. The there's lots of kids, patients coming down from the neonatal intensive care unit, also the pediatric intensive care unit, the hem-onc unit. So these are pretty sick patients. And we're able to see success like Kayla and Sanjay and Jeff are describing, even our most high acuity area. Jeff, do you want to speak to these charts briefly?
Yeah, well, Dan, we didn't dictate what the answers were. It was saying we're going to give the tools and the data to the teams, and then you tell us where you see the improvement options and go from there. So, yeah, happy to address any other specifics. But I think that's the message, is that this approach is agnostic to the precise problem. And instead of me as the administrator coming in and saying, well, you got to, put your left foot in front of your right, you're able to say, hey, but here's somebody who's doing it right. They're calling ahead. They're doing these other, steps that sound so simple it can't possibly make a difference, but it does. Mm-hmm. And then you also build the collegiality and the team approach to the problem.
Yeah. So what we're seeing are these rapid, other industries call it test and learn. If I learn something today because of a discussion we've had locally in our microsystem and I apply it, I can see tomorrow when we're looking at yesterday's or this week's data, like are we starting our case on time? Almost the majority of cases now are starting on time, whereas before it was less than 10%. So, and even though case volume is going up, which is what we're trying to do, 25% increase.
Could I add a little bit to this slide too, Dan? Is that okay?
Please. Yeah, jump in.
I'm really proud of this slide, and I think for the blue is all what we were doing before we built this Max Camp team, and this team meets every 2 weeks still. We were meeting weekly, and now every 2 weeks I'm on that team. And we're consistently looking at these dashboards that are built through AdaptX, and we build them. And this what you're looking at here is the green is just showing that our the top right is our all case on time start. It was dramatically, sort of improved. And also look at the middle one on the right is like the last case actual. You can see we dropped it. So we're actually ending the day earlier through using this data. But what all this does is these bigger, this doesn't solve the problem. This lets us track it. But it allows us to show that our experiments are working, that we're using. We identify who are our top performers through AdaptX, who are the teams that are functioning the best, and let's copy them. And I think but you can see our results have been sustainable. So I'm pretty excited about this.
It's pretty amazing. I'm going to thank you, Sanjay. I'm going to switch tracks a little bit and talk about clinical effectiveness, because in the same way that we've been talking about how you can learn from each other, you can identify best practice, you can do this with clinically as well. So I know a lot of the work, Liz, you were involved with that, with the transitioning away from opioids. Started at the surgery center, then progressed into the main camp. And Kayla, your staff were instrumental in helping everyone figure that out. I've got a slide up here that says, we've reduced length of stay by a day for appendectomies, really as a placeholder, because it wasn't about appendectomies. It was all about, can we improve the recovery profile of our patients coming through anesthesia? Who wants to just kind of riff on this one for a little bit? Liz, if you want to jump in and talk about our experience of, transitioning away from opiates at Bellevue, or Kayla.
Yeah, I'm happy to talk about that. So I think one of the messages from this story, Bellevue, our outpatient surgery center, we work as a care team model with CRNAs, and we've moved away from opioids for over 90% of our cases. They're close to 100% now. And our CRNAs work at the outpatient surgery center, the ASC, and at the main campus. So do the attendings. And so this message of we can do these cases with alternative medications. We don't need these opioids. We have great outcomes. We have shorter PACU times. We have equivalent pain scores, less post-op nausea and vomiting. We started really experimenting with that at our main campus as well. And just through these organic conversations and looking at the data and discussing, can we apply this to other cases that are not day surgery? Can we try it with appendectomies, for example? So having a macro of a suggested protocol that we could populate our EMR with and say, these are the suggestions for how to do this case. The person doing the case can take it or leave it. But what we're finding is, the more people try that technique and kind of use these unofficial or semi-official protocols, that we're really shifting away from opioids across the board. So I think the top graph on this slide is surgeries without opioids at the ASC. So the green is the opioid free and blue is with opioids. And so now you can see, we crossed a threshold and now we're almost 100% opioid free there. And then seeing, that because our teams are mixed between our ASC and our main campus, and we have these discussions in the break room, and when we do cases together, we talk about these things and see what's possible at our main campus as well, and teaching our residents these alternative techniques. And so now thanks for advancing the slide, Dan. This is at our main campus, so this is obviously a much more complex case mix, more complicated patients, inpatients. And we're seeing that same decrease in cases with opioids in blue coming down and the green coming up with the opioid-free protocol. So we're seeing, that we can do these cases without opioids being, routinely given. It's just transformed our practice.
Yeah, and these are huge numbers. As Liz correctly says, the green line is the opioid-free group, and we're now tracking almost 38,000 patients who have switched to these protocols. So the message of the story is not opioids versus opioid-free. The message really is we can actually now use data and actually question even historically established practices. This practice of giving everybody opioids for surgery has propagated the profession for over 60 or 70 years. We can question that, and Liz is going to be talking a little bit about other things we can question as well, like other gases we use that have been established for over 100 years that we can finally actually see the value or lack of value to as well. So our outcomes when we switch, this is a good point. This is the main campus, and when we switched away from opioids, and we were learning, so our cycle of learning was very much faster. I mean, previously, so maybe I'll draw Kayla in. Kayla, you managed the ASCs before we had instant access to data. Can you just describe to the group how often was the group changing the protocols for even our common stuff, say a tonsillectomy or a hernia repair? How often was that happening?
We would do what we call a trial, maybe once a year. Let's just talk big terms here. So what I can explain is everyone knows there's studies like Plan, Do, Check, Act, PDSA. We all have different terms. And the interesting part is I used to always say we're really good at planning and doing, but we're never good at coming back and checking and acting on it. So, and I started here in 2013. So coming in and looking at opportunities for improvement, we would trial something and then we would just assume, oh, it was working well. And then the greatest result came once I had AdaptX at my fingertips. I was seeing on average, docs leaving early every day, or our new iterations and trials anytime we wanted to do something new. We had the ability to pull up the data real time that day and say, this isn't working, or, hey, I think we can do better. Since you guys started your opioid reduction, I think we're already on our 4th or 5th iteration of trying something different. So this is how quick we adapt. Our team is so agile. They adapt, they change, and they're the ones coming with new ideas, leading with evidence-based or new ideas of their own. And I love that our team has zero issues thinking so big outside the box. We always, myself and our medical anesthesia director over here, we always try and say, let's try it small, like let's impact one team. So otolaryngology, let's take one service line. Our CRNAs were like, no, let's do it all, big bang. And it just started changing our mindset of our team. Now, it's a little different also trying to get nurses to understand not giving opioids right away. So it's getting them to change the way they perceive what's going on when a patient hits recovery. So there was a lot of work between myself and our nurse manager to really get them to understand, do we have a kid in a state of delirium, or do we have a kiddo that's actually in pain? So that's been a challenge in itself, but I'm going to tell you, we now use CAPD, and we started that assessment because our nurses were like, how do we know if our kiddo's in delirium versus in pain? We don't want to do the wrong thing. We have staff that ask all the right questions. We have staff that are engaged that want to make and have better outcomes for our families, keeping, healthcare safe. So that's the fun part about what we're doing here with the ability to have access real time with AdaptX.
Thank you. Jeff, before, as we kind of close off this topic on just clinical effectiveness, this slide is for the audience. This is looking at one procedure at the main campus, looking at appendectomies, which is the most common surgery, emergency surgery we probably do at Seattle Children's. And the graph you're looking at is the green line is as we transition away from opioids, and the blue line is the blue line is when we transition away from what we used to do, and the green line is as we're adopting this new protocol. And you can see the length of stay is about a day shorter. Jeff, can you speak to the importance or the relevance? Why does it matter if you can give a recovery profile for surgeries that actually get patients out of hospital faster?
Yeah, well, right. I mean, Dan, I think the first answer, without sounding too preachy or pedantic, is it's the right thing. And of course, so many factors make that economically important. We're in, as many of you out there, in a situation where we're running at bursting at the seams. And so every day it allows us to give access to another child. And obviously the economic value of that, or allows us to not have to go pay for that traveler to cover that extra day. So there's all sorts of very, very tangible reasons on both the top and bottom of the value equation why we want to do this. But I think what's really cool about it, as you described, is that this was an unintended consequence. And when you set up these measures and pursue something that's of benefit, you're going to see these downstream effects. You're giving some examples, but we just see that over and over again, that when the attention is there, when people have the data available to them, then they can start making those manipulations that get us better outcomes.
Great. I'm going to switch track, and as we introduce this kind of next kind of theme, our third theme, which is equity. When we deployed AdaptX, the intention was never it wasn't upfront that this is going to be a tool that can be used, or a solution that can be used to improve equity. But since we're talking about real-world data, one of the questions that came up in the chat is, do you have to collect any extra data? And the answer is no. Your systems are already collecting all this data. It's operational data. You actually capture what language people speak, and what race and ethnicity, and what zip code, and what payer group. You already capture all this. And everything I've shown you so far is just real-world data. That's just sat there pretty much untapped. I'm excited to introduce this topic because it's improving health equity is probably the most important mission we have to do in healthcare today. If you want to improve quality, probably the first thing you should address is tackle equity, because by fixing equity, you fix quality at the same time. Sanjay, you were instrumental at Seattle Children's getting this started. Can you just share a little bit? How did you stumble onto this one? What made you do it? What did you find?
Well, I think, at Seattle Children's, we've been very transparent that anti-racism is probably one of our top priorities right now. And in late 2020, Dr. Ojemann was the surgeon chief, and he said, hey, how can we work together as surgeons to improve our inequities and outcomes? And first thing I said is, what do you really think there is? And then, I know how to use the software, and so I just went in there and started looking by specific populations, and sure enough, across the board, not just tonsillectomy, but across the board in surgery, we have different outcomes by race and by language. And then I thought, no, that's not possible. That's not me, right? I mean, that's somebody else's problem. That's not mine. And so I drilled it down by tonsillectomy, and here's the data you're looking at for our entire group. And then I thought, well, that's my group. That's not me. But then I was able to do a couple of clicks and then look at my own outcomes, and it was the same for me. I had differences in outcome based on race and language as well. And then that was a pivotal moment for me to sort of have a self-reflection. Am I part of this problem? Am I someone who's treating people in an equitable way? And then I sort of shared this data with all of my group, and shared it. And actually, I gave them an envelope at one of our retreats with their own data showing what they were. I didn't want everyone to know what everyone else had, but it was very impactful for people to see that we have different outcomes. But I think there was no finger pointing going on, but more of an understanding this is a systemic issue, that there are barriers to healthcare that we don't even look at for patients that are non-English speaking or lower socioeconomic or different races. And what this data did was allowed me to look specifically at specific populations and then share this across teams. So I presented this data about our group to our hospital steering committee, to our nursing leadership, to our ambulatory surgery center leadership, to our anesthesia leadership, to our own nurses in my ODO group. And everyone has been aware of this problem. And then we actually formed a team to look at how do we improve this. And we think the main issue is hydration after tonsillectomy. So I'm very grateful to Kayla and our ASC leadership that we actually now have just launched a new pilot where we have a kind of a Lego type of chart where you know exactly how many cups of water you're expected or any comfort liquid you're expected to have every day. And so we're trying to get away from language and use other means of communication. But what's interesting, Dan, is is that we improve things even without any launching this project. And I wonder, just sharing this data across all these different forums has changed our unconscious bias to a conscious bias. And we've already seen a drop in particularly I'm really proud of our Hispanic group, which is statistically improved in 30-day return OR since we sort of started doing this work in 2020. And so it's a snapshot. But I think what this does is very quickly give you in your hands the data to say, is there actually a difference? And I think we all know that there probably is a difference. We just haven't looked for it. But now, at least at Seattle Children's, we're looking at it very intentionally. Yeah.
Kayla, did you want to add anything to that? Because I know your staff were pretty instrumental because they're responsible or largely responsible for doing the post-op teaching and education of how we discharge some of these patients. Do you want a minute or so to speak about that?
Yeah, thanks, Dan. So as Sanjay shared, we had a rapid process improvement workshop where we engaged our key stakeholders. So clinic nurses, MA supervisors, all the way down to our PACU nurses and our OR staff, as well as leadership. And coming up with the picture was definitely key, but the greatest aha moment came for us was during COVID and our protocols changed. We didn't have inpatient interpreters as much. And I'm pretty thankful for, I will say, Dr. Ojemann listening and all of us complaining enough, saying how imperative it is to have in-person interpreters for our patients and families. So we changed our protocol pretty quick. Once we learned we were having this issue, our PACU nurses were like, what if immediately once our families were, done with their kiddo going into surgery, we engaged that interpreter right away in the consult room and started doing post-op teaching with the interpreter present and doing it, because sometimes we would have an interpreter leave and a new one come, and sometimes they wouldn't arrive, so we had to do it with a video chat machine. It just wasn't as personable. It wasn't the same experience. So our nurses instantly started doing this without any need for direction or me to tell them, go ahead. They feel empowered to go do this. So I will tell you, our last staff meeting, they literally said, this is a game changer in our PACU, with our families having the information so quickly, they're understanding. And we just rolled out the picture form that we're talking about, like the cute little Lego chart, but it's literally just cups, and telling the family how many cups a day their kiddo should be drinking of a comfort liquid of choice. We normally said Gatorade, but we were missing the mark on some of our families. I didn't even stop to realize how disconnected we were saying Gatorade when Gatorade's not available at an Asian market. And so I was like, here's our aha moment with having the right people involved and engaged by just saying liquid of comfort. If a cold's not working, let's try hot. So it gives the family the ability to literally have the access to interpreters and pictures instead of just saying so many words to them. It's pretty powerful to have our nurses doing the work and leading that work.
Thank you, Kayla. One of the questions that came up in the chat was from Mark Radke, who said, why didn't we look at best practices from other institutions rather than develop them internally? And my answer to that is we did. So a lot of the stuff from the tonsillectomy, from the opioid-free work or the transition was exactly that, applying best practice established in the literature. The difference now is when you apply a piece of evidence or a piece of practice, you can actually see what is the effect on your system locally this week, today, this month. How does it work? So your rapidity, your ability to adapt and learn is much faster. And some of the things that Kayla just described was there is no best practice on how you should educate someone after a day case tonsillitis. There is no national guideline for that. So you have to figure stuff out locally. So there's a little bit of both. I want to just transition to our final topic. And again, when you give smart people tools, amazing stuff happens. And this is really Liz, Dr. Hansen is going to be speaking about this. But before she jumps in, Jeff, just give us a high level. What was the hospital executive leadership team or the CEO's objective with carbon neutrality? What was the big picture before we jump into Liz and the work she did?
Yeah, well, right. And just as with health equity, where I think every leader there saw the pattern of, which hopefully we'll get better and better at, of setting the cultural standard, what the expectation is, and then looking for first and second leaders and first followers, and then giving them the tools. Similarly, we know that the climate change is an active crisis in, really obviously for the planet, but also specifically for pediatric health and the changes there. And hospitals, including ours, have committed to carbon neutrality. The perhaps surprising thing is how much specific factors such contribute to that, and in particular waste anesthesia gases, because the gases we use have many orders of magnitude exaggerated impact as greenhouse gases. I think that's we've subscribed to the consortium committed to changing this, but we need to do it. And I think just as with health equity, the talk and the commitment is the first step, but the second step has to follow immediately. And Liz has led the way on. As you'll hear.
Top down kind of direction, and then it's up to frontline folks. Liz, tell us, how did you get started this work, and how big is this problem at Seattle Children's?
Yeah, I mean, as Dr. Ojemann said, it's a big problem in all of healthcare. Healthcare globally is responsible for 4.4 of global emissions, contributing to global warming, pollution, and that's directly contributing to disability and death, especially in our vulnerable pediatric population. So this is something that we're seeing the effects of, and we're contributing to. So it's a big source of problems. Locally at our institution, we have a commitment to sustainability. We have this goal of carbon neutral by 2025. So when I came on board as a junior brand new faculty member in 2017, I met with Colleen Grohl, who was our sustainability manager, and she showed me the data that she'd been collecting. So Practice Green Health has a tool where hospitals can add up all their emissions from scope 1, 2, and 3. And part of that is the emissions from anesthesia gases. And as Dr. Ojemann mentioned, these are really potent greenhouse gases. They're really good at warming the planet, a lot more so than CO2. So Colleen showed me that of our hospital emissions, which are exceeding 18,000 metric tons of CO2 equivalents, 6 or 7% of that was coming from anesthesia gases. So that was 1,200 metric tons in 2020. So that's like burning, 1,300,000 pounds of coal. So this is a huge problem. What we didn't know is exactly where this was all coming from. So we know that there's some really bad actors. So desflurane is really potent, and nitrous oxide is really potent. So there's already some recommendations from the ASA and other organizations to, really reduce use of those things. So we kind of started with that, some education with the group and saying, let's get rid of the desflurane, which is the worst one. It's 2,500 times as potent as CO2. Its global warming potential is that high. So you can see in this top graph here, this is our main campus average CO2 equivalents in kilograms per minute per case, that we started off really high. So this is greater than 0.3 kilogram, or actually, about 0.3 kilograms per minute of CO2 equivalents. And then we said, okay, let's get rid of the desflurane, and that's where our first big drop came from. And we continued with educational efforts with other strategies that have already been established to reduce waste of these gases. So turning the flows down on the machine, things like that. And then what really changed the game is getting this data into AdaptX. So contrary to some of the other metrics that we've looked at, This isn't something that's automatically being captured in the EMR, but you can calculate it from things that are being captured by the EMR, like our fresh gas flows and our percent of these different gases that were being used. So using math that's already published and the global warming potential, so how you kind of can transform the equivalence of one into another, we could calculate the carbon dioxide equivalence of each anesthetic and then pull that into AdaptX using data that's already being collected. And so once we had that data, then we could see what are our highest emission cases, who are our highest emission providers, who are our lowest emission providers, and then talk to them. What are your strategies? What are you doing to be a low emitter here? And so that's some of the data that's being shown here. And this is something now I send out to our group every month, and I say, hey, this is how we've been doing the last month. These are the people who've been really driving our emissions down. And then also which cases we're seeing, where we've made improvements. So by talking to the people who have gotten their emissions really low, we've learned some strategies that then we can recommend to the entire group. And these are along the lines of things that are already published out there, but we were trying to do that before with just educational measures. And now that we have the data, we can say, okay, this is actually working. So one of the things that we did, we saw that our ASC, we had higher average emissions. And that was in part because we had short cases, and a lot of the emissions come from the very beginning of the case when we're going to sleep with the anesthesia gas through a mask. We're using nitrous oxide, which is almost 300 times as potent as CO2 at warming the planet. And so those inductions, that start of the case was contributing to really high averages. And we looked at that and saw, okay, maybe we can change how we're doing these inductions. Maybe we can try it without nitrous oxide. And so we actually unplugged the nitrous oxide hoses from the wall, and we learned that it was actually worked just fine. We had pretty good experiences with these families. We had to kind of learn how to change what we were doing since it was new for everyone, including people who've been practicing for decades. But we found, it didn't change our anesthesia ready time. It didn't change our PACU length of stay, our pain scores, our nausea rates, anything. It was really actually pretty smooth to transition. We just needed a commitment from everybody to try it. And it's been working so well, we don't need to go back. Part of what was so important about this data and seeing this, we've had this 9 or 10-fold decrease in our calculated emissions that we're getting straight from our EMR. So this is based on fresh gas flow and volatile use of our anesthesia gases. But I still had our sustainability team giving me the data annually based on our purchasing data. That was that practice green health metric that was showing us 6 to 7% of our total emissions coming from anesthesia gases. And that was staying the same or just coming down very minimally. And so we looked into this and we realized that this is probably because our nitrous oxide central supply tanks are leaking. This is something that's just being kind of discovered. There's some work in Scotland that has done a big analysis looking at these tanks. And then Brian Cheeseborough, the medical director for environmental stewardship at Providence in Oregon, has also done some work on that and discovered that these central supply cryo tanks are leaking 1 to 2 liters per minute, regardless of whether they're even being used. So this is now prompting us to evaluate everything in our facilities, and we can probably cut out another 90% of our total emissions, which is coming from these leaks.
Great. Well, thank you. I'm just going to summarize. There's a lot of information there for our audience. I think and just jump in if I got it wrong, your work and your team's work has led to a 9 or 10-fold reduction in carbon emissions. That represents about 7% of the entire hospital footprint. As a consequence of your work and measuring stuff that was derived from the EMR data, you've also identified this massive leak. Like, we're buying thousands of tons of nitrous oxide, 90% of which is wasted before it ever gets to the patient.
Yep.
Okay, so this ties up this whole conversation really nicely, Liz. As we move away from these graphs, all the dots represent physicians. You can get down to physician-level performance for any metric you want, including like carbon impact. But as Dr. Parikh was saying, also with equity outcomes, and then as Dr. Ojemann was saying, also with clinical outcomes and capacity and throughput. So the ability for our frontline staff to do creative things once you empower them with their tools is amazing. We just have 2 minutes left before we move to the Q&A. Jeff, I just want to turn the floor back to you. You were on the executive leadership team, a couple of years ago when we decided to democratize and decentralize the data, believing that your frontline teams would do amazing things. I'm going to give you the last 2 minutes to close out and say, what else are you seeing? Where's the future go? Should we be doing more of this? What is your advice to other people?
Yeah, so the first was getting the message out of these successes. As you know, we then had a lineup of divisions interested in this. Every single ICU unit, the emergency department, urgent care, and fortunately we're able to cycle through this now quite quickly. I'm sitting here listening and realizing the other great power in addition to democratization is the speed. I learned to ride a bike in a couple of weeks. I learned to be a neurosurgeon. Took 10 years. I'm still learning how to write grants after 35 years. And it's because of the speed of feedback and that's what drives learning. And so, this is the power, right? You can get feedback from other tools and other mechanisms, but to be able to do the intervention, see the results, and then change and go to the next step at a cycle that's so much faster. That's what's going to, to me, makes this such a powerful tool. So, we'll continue to report out and share as we have successes and failures. But I think that the cultural impact of this, which we're still on the journey of, but that can't be underestimated. The ability, look at health equity where we've said, yes, these things are bad, and actually you can be part of the solution. That is a foundational change in how we approach the problem. So thank you, everyone, for your work in this. It's really, I hope we've shared the impact.
Yeah, well, thank you. And we've heard such a broad range of stories of how it's being applied. And I'm just going to open up the floor for Q&A. I know there's some questions in the chat box already, and we'll try and hit some of them. We have, there's a technical question. It's like, is AdaptX getting the data from a warehouse? Yes. What warehouse do we use? It doesn't matter what warehouse you have. If you warehouse your data or if you don't warehouse your data, we can ingest it. There's some technical questions. How easy is it, difficult to pull the data? Well, that's the whole point of having an electronic medical record. It's a million times easier than pulling it from a paper chart buried in a physical warehouse. Now it's all electronic. It's a relatively simple step to stand up any hospital. That was the whole point of the last 10 years, was to stand up EMRs so we can do this kind of exciting work. So please keep the questions coming, and as they come, Courtney or Lisa, just keep fielding them, and we'll see which ones can we hit. We had
They're in the chat, Dan, to make it easy for you.
Great. Well, here's a good one. What do you do? What would you say to a hospital another hospital who's listening, who says, "Hey, we have tools like BI tools like Tableau and Power BI and ClickView." Kayla or Sanjay, maybe you want to hit that.
Yeah, great. Yeah, I can speak to. We have a similar software package called Tableau here. I think it's actually a local Seattle company, which can be quite effective too. I've had to train myself a little bit how to use it, and I think it's a great software package. But for me, the advantage of the AdaptX is that it's just a little easier for someone who's not a big data person to quickly grab data, pull it in, and get the outcomes you need. So the learning curve is much shorter. At least for me, was much shorter, like hours versus days for training to understand how to use one package over another. And it allowed me to do, just like Dr. Ojemann and Kayla mentioned before, that PDCA cycle gets quicker when you're able to grab the data yourself. Otherwise, with Tableau, I need to partner with someone, an informatician locally, to really get the data.
I agree. Yeah. That I think the learning curve for me was 20 minutes, Dan. Once you gave me access and I learned how to pull the data in, I was off and running. And sometimes in the very, very beginning of conception of AdaptX, I could work faster pulling data than the system could even keep up with me. In regards to Tableau, I have to rely on other people. I've never been trained at Tableau. And so it's definitely an issue for me as a nursing leader who has these continuous ideas and wants to check back. I don't have the ability to just jump in, build what I want, and see how things are going. Relying on other people just doesn't make sense to me. when I have this right at my fingertips.
Yeah, I think, thank you for both those comments. Those other tools people mentioned are generic business intelligence tools. Number one, not specifically designed for healthcare. And number two, really designed for analysts, data analysts who are pretty sophisticated to use. And so that using those BI tools, a human being could create a report for any of these panel members to read, but it wouldn't be instantaneous. And, you know, Seattle Children's is a HIMSS level 7. It's about the highest you can go on sophistication. And they have a dozen clinical-facing analysts who are all superb. But they're serving 600 physicians and a couple of thousand nurses. So the ability to keep up with the demand, none of the work you've seen this morning would have been possible if you had to wait a year for data or 6 months for a report. So the creativity and the innovation occurs when you're able to ask your own questions about your nuanced questions about your specific microsystem that you're involved with. So thank you for that question.
Yeah, can I add to that too, just 2 examples of when I've used AdaptX, not for the climate work that I've done. A lot of times when I'm working with residents, they'll ask me a question about why we do something the way we do, or, you know, will this medication cause, you know, the patient to sleep longer in the PACU, something like that. And I can say, well, we're working together, you know, well, let's just look at the data. And we pull up AdaptX together, and within 5 minutes, we can see the data from the last however many years of all these thousands of patients that have received this drug versus a different drug, and how long they sleep in the PACU, and get the answer in our own population, our own real world data. So that's one thing. Yeah. And then another thing is, and you kind of mentioned this with the max cap work at the beginning, but, you know, the start of the GI efficiency project happened in the break room over coffee when one of my colleagues said, hey, you know, why don't you do your GI cases this way? My patients all wake up really quickly in the PACU. And we thought, oh, really? You're that much faster than us? And so we all just kind of gathered around the computer and pulled it up in AdaptX and looked, and actually he was right. And his patients were out of the PACU 20 minutes faster than everybody else's. And so then we said, well, maybe we should all do it this way. And that was kind of the start of one of these really big max cap projects that generated then so much more capacity in the GI suite to do more cases. And it just literally started over coffee. So I think that's one of the big differences. It's just so easy to ask a question and get some data to generate, you know, a whole nother project, or just do some teaching with the resident.
Yeah. Dan, can I just say something about that too? Dr. Hansen's being modest. I mean, that's incredible what they did. But this speaks to someone else asked earlier on, why don't we use someone else's clinical effective tools? When we do that, we don't get the buy-in like what you just heard, right? When people in the grassroots can look at the data very quickly and see their own outcomes, it's much more powerful than reaching out externally to pull things in. Because there it feels like someone's pushing onto you to do something. Here we're pulling the data ourselves and able to create our own ideas and projects and then cycle back and look at them.
Yeah. That wraps up, I mean, both your comments with Dr. Ojemann's comments about riding a bike and how long it took to become a neurosurgeon, and the rapidity, that instant feedback loop is so key. You know, Dr. Hansen describes moving away from anecdotes and who tells the best story to actually what happens. And in terms of, you know, I've been practicing for 25 years. I have learned more in the last 2 years than I had in the previous 20 years, because as Dr. Hansen said, I can pull up, you know, 2,000 patients that had this combination of drugs for this, and I know their outcomes. Well, that would be a lifetime of work. In 20 years, I might have seen 2,000 patients of that type. But now I practice as if I have already treated 2,000 patients of that type. And so everyone's knowledge, it doesn't matter if you're a first-year resident or a 25th-year veteran attending, we're all able to learn at a pace that was previously thought to be inconceivable. Marlene, thank you for your last question. How do we learn more about AdaptX? I'll put up my contact details there, and you can contact me directly, and we can certainly share some of these stories of your team at your hospitals or your leadership if they're interested in finding out some more. We have 5 more minutes before we have to close out the webinar. Please keep the questions coming. Lisa or Courtney, if you see something else that you want us to hit, just put it in the chat. One
Yeah,
question
Dan,
we have,
I think you covered all. There was one that actually talked about best practice. Was it developed internally? Why not just adopt best practices from outside hospitals?
Okay, we can, yes, I think I addressed that in a previous comment. We did, and said you can apply evidence-based medicine, which is best practice published in the literature. You can apply it locally. Now the difference is you can say, hey, when I look at evidence, I can look at, trial-based efficacy. That was done in the Mayo Clinic 25 years ago. How does it work in Seattle in 2022? Everyone has understood there's a gap between trial-reported efficacy and real-world effectiveness. We're now in a position to measure that. Let's try it for a week. Someone said it was a good idea. Let's see if it works, and I'll tell you next week if it works. That's the difference. We weren't able to do that before. One question is, curious how you identified and validated data elements from the EHR to visualize. The theme, everything I've showed you is real-world data. It's data that you routinely collect, usually for the purpose of billing. For the capacity work, you fill out a time they hit the operating room, when they leave, when they hit PACU, when they leave, what time the knife goes in, what time the dressing goes on. You capture these timestamps. You also capture all the medications and the hardware and the widgets and the medical devices, usually because you have to document it and it's good practice, but also for billing accuracy. So we're using the operational data that's sat there unharnessed and unused and unloved, and we can actually do some amazing things with it.
Yeah, and Dan, this is Jeff. I just point out, we're pursuing trends. It's the exact number is rarely important. It's the trend and best practice and moving at the right direction that matters. And I just want to emphasize too. I mean, I don't have numbers to report yet, but it's very clear we're going to have both a financial ROI here as well as cultural impact. And really, as we focus continually on physician engagement and burnout, the ability to build agency here is very clear. Not to call out your anesthesia team, but there's no question, watching it over the past few years, that the spring in folks step is very different, despite most of the world going the opposite direction.
It's been an amazing journey, and really watching the sheer number of improvement initiatives. It's not that we didn't do it before. We've been on this lean journey for 15 years, as everyone on this call knows. But it was painful. It took 4 or 5 years to finish each cycle. Now we're finishing each cycle every 4 or 5 weeks, and just the sheer number of initiatives springing up spontaneously. When we look at the clinicians, we have several hundred clinicians hitting AdaptX. When we look at it, most people 80% are hitting it between the hours of 6 p.m. and midnight. What does that tell you? It tells you have an engaged staff who are curious and hungry for data, and they're noodling on this in their own time after work. And it's that innovation is never ordered, it's volunteered, and that's what we're seeing. And because we're on a mission to make healthcare better for children and for all our patients. And so we're and it shows in our staff who are mission driven, and this is a tool that's going to help accelerate to improving that mission. I'm going to close out. I think you can see my slide. If you can't, again, my name is Daniel Lowe. I go by Dan. I'm the Chief Medical Officer here. My email address is dan.lowe@adaptx, ADAPTX.com. And you can reach me directly, and I'll be happy to share some more case studies or talk to your leadership. And I thank everyone for their participation. Dr. Ojemann, Dr. Parikh, Dr. Hansen, thank you so much this morning. And Kayla Reese, thank you so much. And everyone have a great day. Thank you.